The second session will be a case presentation from the General Hospital, Ernakulam. This is a case of an interesting multisystem disorder in an adolescent girl. The case will be presented by Dr. Imran, a final year DNB student. I invite Dr. Prasanth, Senior Consultant Physician, General Hospital, Kochi, to conduct the proceedings.
Respected office bearers of the API, Dr. Abraham George, Sumesh Chako, and respected senior physicians and teachers. I am Dr. Prasanth. I am a consultant in General Medicine and General Hospital, Ernakulam. And at the onset, I express my gratitude to API Ernakulam for inviting us, for giving this opportunity to present this case at the August gathering here. And as told, it is a multisystem disorder. It has been evaluated by our DNB student, Dr. Imran, and it is over to Imran for his humble presentation here.
So, the case is a 16-year-old student from Cochin, and information obtained from herself and mother, and the information is reliable. And her chief complaints was knee pain for 14 days, edema and pain over both feet for 10 days, reddish lesions over both lower limbs and hands, fever, redness of eyes, pain on both shoulders and joints of hand, oral ulcers lasting for last 10 days. She presented with these complaints, and I am going to elaborate the history. Her first complaint was joint pain, which was started 2 weeks back as a knee pain, which followed by ankle, shoulder and small joints of hand. And the joint pain was diffuse around the joint, and it was symmetrically involving on both sides, and there was no swelling, no redness around joint, and no morning stiffness. Her next complaint was edema over both lower limbs, which started 3 days after the onset of knee pain, and which was started on both feet, and it progressed up to knee. And the edema was pitting by her history, and it was associated with the pain over ankles. And later she noticed edema over hands also. And there was no associated frothing of urine, discoloration of urine, facial puffiness, abdominal distension, and no associated cardiac symptoms. Next complaints was reddish skin lesions. It was initially present over the feet, and lesions are varying in size from 1 millimeter to 2 centimeter size approximately, and the similar lesions also found on upper limbs also, and there was no history of other bleeding manifestations. And she was also having fever, which was low grade and which was continuous, and there was no associated chills and rigor, and there was no associated respiratory or GI symptoms. And she was also accounting history of redness of eyes, which was not associated with discharge, photophobia, visual disturbance and pain, and for which she was consulted an ophthalmologist and has prescribed some eye drops, and which the redness of eyes was subsided after 3 days. And she also had oral ulcers, which was present over both sides of tongue and also on palate, and which was painless as per her history, and no genital lesions. And the past history, there was no similar illness in the past, and there is no relevant past history, and she was fully immunized up to her age. And she is the only doctor born out of non-consanguineous marriage, no similar illness in the family. Personal history was her sleep and appetite was reduced, and she had a normal menstrual history. Socioeconomic status, she belongs to a low income family. To summarize the history, the case is a 16-year-old apparently healthy girl coming from a low income family without any significant past medical history, presented with complaints of arthralgia, fever, erythematous lesions over skin, edema over extremities, oral ulcers, without any other bleeding manifestations. So,
Yes, this is the short summary of the patient, and it's a it is a symptoms, complaints of arthralgia, skin lesions, fever, and oral ulcers. Any possible DDs which can we think of?
no history of abdominal pain. She was saying pain over the joints. Urine was normal.
No, HS purpura is a similar. But arthralgia, skin lesions are there, arthralgia will be there. Yeah, everything will be there.
Pattern in
pattern?
arthralgia initially noticed of the large joint, knee joint, then also on the shoulder joint. No specific pattern was obtained, and also having small joint involvement also. It was diffuse, not migratory type.
Not migratory. Let's go on to the other examinations. We also consider the DD of a viral exanthe and acute rheumatic fever, vascular disorders, tuberculosis, juvenile arthritis, and Kawasaki disease are the least, because even though it is a pediatric problem, we also consider Kawasaki disease. There is an increase in the incidence of Kawasaki disease post-COVID. That's all. Okay, then go on to the.
So we proceeded with the examination of the patient. On general examination, she was conscious oriented, and there were palpable purpuric lesions over lower limbs, mainly at the feet and ankle, and there was also reddish lesions in the hand over fingers, and the lesions are not blanching on applying pressure, and the lesions were discrete, and the lesions are not confluent. That means, and these are the images showing the lesions, mainly over the lower limbs, and few similar reddish lesions also over the upper limb. The lesions were palpable. Appearance wise, she was looking anxious, and we examined the oral cavity. Oral cavity was showing superficial ulcers on the both sides of tongue and palate. And the joints, we examined the joints, the tenderness was present. Hair and nail, genital area, all things was normal. Image showing the oral lesions over both sides of tongue. There is edema over the hands, especially over the distal interpharyngeal joint. And she was underweight according to BMI. And vitals, she was having a she was having a tachycardia. Otherwise, the pulse was normal and having a normal BP, and she was febrile. Her respiratory rate was mildly elevated. And she was pale, and bilateral pitting pedal edema was present. So we proceeded with the system examination. First, examined the locomotor system, and there was swelling noted over the bilateral lower limbs, extending from DAP joint up to knee. The swelling was diffuse and not confined to any lower limb joints. And we also examined the upper limb joints, which was showing tenderness over the small joints of hand. There was no local rise of temperature, and the movements was full. Range of movements was full, but there is painful restriction. And also the muscle power examination was limited due to the pain. Her spine was normal and gait was analgesic. We examined the cardiovascular system. No significant abnormality was obtained from the examination. Central nervous system, the gait was analgesic. No other significant abnormality was obtained. Respiratory system, we examination started with upper respiratory tract, which was normal, and the rest of the respiratory system examination doesn't reveal any significant abnormalities. And the oral cavity there was lesions over the tongue and soft palate, other gastrointestinal system examination was normal. So to summarize, after the examination, a 16-year-old girl presented with from a lower class family without significant past medical history, complaints of arthralgia, fever, erythematous lesions, edema over extremities, oral ulcers. Examination revealed she was febrile, pale and palpable purpuric lesions over extremities and superficial painless oral ulcers, bilateral peeling pitil edema and polyarthralgia. And there was no system examination, doesn't reveal any significant findings.
Yes, except for confirming the presenting symptoms and presenting symptoms, there was no evident systemic signs we could be elicited by the examinations. Then we are proceeded with the investigations. Yes.
We made as assumption of vasculitis syndrome because of the palpable purpuric lesions, and we considered possibilities of small vessel vasculitis, secondary vasculitis due to collagen vascular diseases, and we even considered Behçet's disease, even though there was no characteristic genital lesions. We proceeded with investigations. Investigation revealed she was having anemia, and there was a drastic fall during the hospital stay, and there was leukocytosis which was persistent, and the platelet count was normal, and the inflammatory markers ESR, CRP were markedly elevated. On urine routine examination, there was microscopic hematuria, RFT normal, and LFT was normal except for mild elevation of total bilirubin. And her viral markers was done, which was negative. Viral markers including HbSAg, HCV and HIV. And we, since she was having anemia, we evaluated the anemia. Recti count was 5%. Reticulocyte production index was 1.13, and the peripheral smear was showing microcytic hypochromic anemia. LDH was normal, DCT negative, and stool occurred but turned positive, and we planned for endoscopic evaluation. Then patient was deferred the same. Further, we proceeded with ANA profile, and ANA profile was negative to rule out the secondary causes of vasculitis, and RF was mildly positive. And since she was having fever, we also obtained cultures. Culture was sterile, urine and blood culture. ECG was normal except for sinus tachycardia. In view of microscopic hematuria, we proceeded with the ultrasound abdomen, which was showing bilateral hyperechoic kidneys with early loss of corticomedullary differentiation. Then we took chest X-ray as a routine, then found out lesions, which was cavitatory lesions over bilateral lung widths, especially in the mid zones.
The investigations revealed anemia, a mild hematuria, and increased inflammatory markers, and cavitatory lung lesions. These are the positive things that we could get. And in the ultrasound showed mild renal involvement also. Any disease we can think of? Sputum AFB was a patient didn't have any cough, but it didn't. Patient we cannot do CB-net. Not done.
We proceeded with the investigation. To rule out tuberculosis, we have done, the sputum was not available. We have done the Mando test, which was negative. And the echo was normal. And we proceeded with the CT thorax to evaluate the chest X-ray finding. And the CT was showing multiple cavitatory nodules over the both lung fields. The image showing multiple cavitatory nodules. The cavity was thick-walled cavities, having a thick-walled cavitatory nodules on the both lung fields. And we discussed with the radiologist regarding the same findings, and she also confirmed the findings, and she suggested possibilities of infective etiology like tuberculosis and inflammatory etiologies like vasculitis.
There was no features or any symptoms of tuberculosis. The chronicity of the disease also does not point to tuberculosis. And essentially it is a cavitatory lung lesions, inflammatory disease, anemia and hematuria. Okay then. No sir. But there will be respiratory symptoms. No cough.
No cough. No respiratory symptoms.
No cough. Yeah, we are
Yes.
We are thinking in that direction, and it will come soon. Yeah.
From the lesions, we also done some skin biopsy, which was showing only lymphocytic vasculitis. And we have proceeded with the way that whether it is a vasculitis or a tuberculosis, and TB was the sputum was not done and MANDA was negative. We also think of ANGA, and the C-ANGA found to be markedly elevated.
Hematuria, renal involvement, lung involvement in the form of cavity, C-ANGA positive. It is.
And we clinchered the diagnosis of granulomatosis with polyangiitis with multisystem involvement.
The vaginous granulomatosis, the earlier nomenclature.
Previously known as vaginous granulomatosis.
Yes, then go on. Any clarifications here? Microscopic polyangiitis, this C-ANGA positivity is more in case of vaginous GPA. Microscopic polyangiitis is less. And another thing is microscopic polyangiitis is having more of renal involvement also. Renal and some respiratory symptoms will be there. Cough.
Cavitatory nodules are not seen in microscopic polyangiitis. It is classical of vaginous granulomatosis, now known as granulomatosis with polyangiitis. Microscopic polyangiitis does not have granuloma, so these cavitatory nodules are manifestations of granuloma formation. So that is not seen in microscopic polyangiitis. And we are, although ANGA may be positive in eosinophilic granulomatosis with polyangiitis, there was no symptoms, respiratory symptoms, so there was no history of asthma in the family also, and there was no peripheral eosinophilia. These findings are suggesting EGPA was not present in this patient.
There are only few conditions which will produce a thick-walled cavity. Okay, then we will go on with the other follow-up.
We managed the patient with giving pulse regimen of methylprednisolone, and after ruling out the infection, whenever we got the culture sterile, the patient was started on injection rituximab. And the patient improved clinically day by day, and we have planned the patient to taper to oral steroids, and the second dose of rituximab was given after the 1 week. After 2 weeks, the patient is reviewed in the OPD, and the patient was clinically better, and her oral and skin lesions are disappeared, and there was no new symptoms. We took a follow-up chest X-ray, which was found there was the disappearance of bilateral lung cavities and nodules, and the inflammatory markers ESR and CRP came down to normal. So, causes of palpable purpura include vasculitis, maybe a small vessel vasculitis or a small vessel involvement in the medium vessel or large vessel or variable vessel vasculitis, or vasculitis due to secondary cause connective tissue disorders like rheumatoid arthritis, SLE, sarcoid, and Sjogren syndrome, and drugs producing vasculitis and malignancy, especially lymphoproliferative malignancies. And the causes of thick-walled cavitary lesions, granulomatosis with polyangiitis, squamous cell carcinoma, lung abscess, blastomycosis. And the causes of Chianga positivity, in 70% of granulomatosis with polyangiitis having Chianga positivity, and which is 40% in MPA, which is 20% in renal limited vasculitis, and only 5% is EGPA. And the causes of Pianga positivity, typical Pianga positivity is seen in 70% of renal limited vasculitis, which is 50% of MPA, 40% of EGPA, and 25% of GPA. And drugs causing vasculitis, drugs causing Pianga positive vasculitis, hydrolysine, propylthiouracil, minocycline, and levamisole adulterated cocaine, and Goodpaster syndrome. Atypical Pianga positivity, autoimmune hepatitis type 1, primary sclerosing cholangitis, rheumatoid vasculitis, IBD, and cystic fibrosis. The treatment options for ANGA positive vasculitis, mainly the treatment is divided into induction phase and maintenance phase. For induction, for the severe disease, we can start on glucocorticoids plus cyclophosphamide, or another option is glucocorticoid with rituximab. And the selection of the choice of the drug is depending upon the severity of illness, whether the illness is new or whether it is a relapse case, and also considering the patient factors, especially the fertility concerns and the tolerance to the drugs. And maintenance may be continued on rituximab, azathioprine, methotrexate, or mycophenolate mofetil. In non-severe cases, we can also use methotrexate, MMF together with the corticosteroids. This case was presented because this case is a very rare case in blacks, especially in young patients. Incidence is only 3 per 1 lakh. Approximately 15% of the cases, only the 15% of the cases are less than 19 years, and the mean age of onset is 40.
Actually, it is a very rare presentation. Usually the age is around 40, and more in case of Caucasians and white population. This patient is ours is a girl of 16 years old, but she presented very early. Luckily, she was diagnosed early before any ominous respiratory or renal symptoms develop, and she has been treated. And even though she is from very poor income family, we managed to get her into the insurance system, and treatment was provided free from the hospital. And happily, she recovered from her symptoms, and even her lung cavities, lung lesions also subsided with the treatment.
This is the diagram showing the classification of vasculitis. Main classification is large vessel, medium vessel, and small vessel. Large vessel we have Takayasu arthritis, giant cell arthritis, and medium vessel we have polyarthritis nodosa and Kawasaki disease. In the small vessel we have immune complex mediated and ANGA associated vasculitis. ANGA associated vasculitis we have microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and granulomatosis with polyangiitis. And we have immune complex mediated vasculitis, cryoglobulinic vasculitis, and IG vasculitis, which is also known as henoxolin purpura, and hypocomplementemic urticarial vasculitis. Now the latest classification also have a classification of variable vessel vasculitis, which includes Behçet's disease and Cogan syndrome. And we have also a class which is known as single organ vasculitis. Examples are primary CNS vasculitis and cutaneous lymphocytoclastic vasculitis. So thank you all.
Any other inputs, comments from the audience?
Congratulations on presenting this from General Hospital.
Yeah, thank you. Yeah, we have done a very, I think with our limited resources and considering the income group of the patients coming to our hospital, I think that patient is very lucky, I think. That's all. Yeah. Okay, then thank you all. Thank you.